presentation, I will describe the work we did on de-identifying the Heritage Health Prize dataset. So the Heritage Health Prize, as I think many of the folks who are in attendance know, is the largest healthcare analytics competition that's been held thus far, with a large cash prize for the winner of the competition. It lasts for 2 years, and given that health information was going to be disclosed online to a broad community, global community, of course privacy was a concern. We were asked by Heritage Provider Network, which is the data custodian or the owner of the data, to do the identification for this data set. So what I will talk about today are the steps that we have taken, the rationale behind those steps, the various methods that we used, and also describe some of the lessons learned going through this process. I should also mention that there is a complete article, an article with the complete details that has been published in the Journal of Medical Internet Research. And the link is there on the screen. And this article, which came out last week, provides a lot of the technical details around the methods that we have used. So I would encourage you to go to that article and to get more information about the approaches. And of course, if you have any additional questions, please feel free to send me an email afterwards as well. I'm going to try to address concerns that have been or questions that have been raised and concerns that have been expressed around the creation of open health data, but also try to present them in a way to meet the needs of different communities. One of them, of course, are the entrants in the competition, and I see that some of the attendees today are entrants in the HHP competition, so hopefully this will help you understand a little bit more about what was done to the data that is being used for the competition. I'm also trying to address some of the issues that may come up from the disclosure control community in terms of the choices that we made and the techniques that we used, and also the needs or questions that other competition organizers may have should they want to organize similar competitions to the HHP. I think HHP set a precedent and covered new ground in terms of large-scale open health analytics competitions. The other community that I didn't explicitly mention here are the open data or open government community, which is also interested in making just data, some of it potentially personal information, but certainly data publicly available for the benefit of the citizenry. And I think also that community would see some value in the various points that I will be covering today. Just a couple of caveats before we start. I'm not going to talk about certain manipulations that we did to the data, and certain information is not mentioned in the article that was published, and there are a number of reasons for that. If you notice things in the data set that may not fit exactly what I said, that was deliberate. Although there are not many of those, but there's some key pieces we decided not to reveal. The other thing I want to mention is I do not represent the Heritage Provider Network or Kaggle, who are running the platform that the competition is deployed on. And therefore, any questions about the competition rules, I know on the forum there have been many questions around the rules, and about the scoreboard and the milestones and so on. I would not be the best person to answer those, so you'd have to go back to the forum, post them, or contact Kaggle directly. However, anything related to the identification of the data set, of course, that's what we did, and I'd be happy to answer those. So some basic principles to keep in mind regarding the identification of a health data set in the U.S. This is an American data set, so we're really talking about the HIPAA privacy rule in the U.S. Of course, different jurisdictions have different privacy laws, and the considerations may be different in other jurisdictions, but here we're talking about HIPAA as the HIPAA privacy rule as the set of regulations that defined the parameters that guided the identification that we did. As part of the process of de-identifying the data set, which took a number of months, we did create multiple versions of the data set, and some modeling was done on the data set to see what impact the identification had on it. And we tried to reach a balance between the impact on the model results and the requirement to protect the privacy of the Heritage Provider Network members. And of course, it's a balance. There are always these trade-offs, but a significant amount of effort was spent trying to achieve that balance, to provide guarantees that were necessary to be able to make strong claims about HIPAA compliance, but at the same time ensure data quality as much as possible to have an effective competition. I should also mention that we had extensive discussions with other experts in the disclosure control community along the way, and I think that the work we did is reflective of what we considered good practices in this space, given the discussions we had with other members of this community. We didn't talk to everybody, but we spoke to some leaders in this space in order to get their perspectives on the approaches that were being used to make sure that nothing was missed. Also, the identification we did was informed by known re-identification attacks. We did a study that was published at the end of last year in the PLOS ONE, the Public Library of Science journal, which is a review of all known re-identification attacks, and up to October 2010, this publicly known re-identification attacks and re-identification attacks on health data sets. And the approach we used was informed by those publicly known re-identification attacks, in order to understand how the attacks were launched, what kind of information, auxiliary information was used to launch those attacks, and so on. Rather than rely on theoretical arguments or hypothetical arguments regarding what may be possible or what could happen, we tried to be evidence-based as much as possible, and relied on the evidence from that systematic review regarding actual re-identification attacks in order to inform the approaches that we used. A couple of things to note about the original data set. First of all, the original data set had a lot of missingness in it. So I know that if you're an entrant in the competition, you'll notice that there's missingness in the data. Not all of this missingness was introduced as a consequence of the de-identification. The original data set, it's a real data set. It came out of production databases, and the original data set had a good amount of missingness in it, and a good example of length of stay variable that had a lot of original missingness in it when it came in, and for some. It's obvious for why length of stay would have missingness. Some patients were not inpatients, or some members were not inpatients during a particular visit. They came in and left on the same day. So length of stay would not be completed, would be null. One thing I should also mention is that we're physically based on the campus at a hospital, and I do apologize. You may hear stat calls to emergency or to resuscitate a patient, so I'll mute those should they happen. So if you hear a moment of silence, that's probably because I'm muting the line to spare you the pages to physicians. Anyway, so the data came from real production systems, and there was missingness in the original data. It was not all induced during the identification process. The other thing to note is we do not have names for any of the patients. So from a perspective of launching re-identification attacks, and evaluating ourselves low-share identification attacks and evaluating how easy it is to identify patients, we could not do this because we did not know who these patients were. We did not have names or addresses or anything about the patients beyond the fields that were included in the in the competition data set. Of course, we had more details, but it was essentially the same set of fields. Therefore, a lot of the risk assessments had to be done using estimates and simulations, which I will talk about as we proceed through this presentation. The other important thing to note is that the competition dataset represents a small sample of the heritage provider network members. Subsampling from a re-identification risk perspective, subsampling is of course a very effective way to increase uncertainty and reduce the probability of a correct re-identification, and this dataset is a subsample. It was deliberately selected to ensure that the overall risk is acceptably low, so you don't have the complete members over the 3-year period. These are for each year a random subset was selected in order to create the total 113,000 patients over the 3-year period. The other thing to mention about the data set is we did very little cleaning of the data. The intention was to allow the creation of models that would work on real data sets, because at the end of the day, a model that would be constructed would have to operate effectively on real data that comes out of production systems. So I'll talk a little bit about the HIPAA privacy rule, which provides the framework for the work that we did. The HIPAA defines, the privacy rule defines 2 standards for the de-identification of health information: the safe harbor standard and the statistical method. In general, HIPAA is more precise than privacy laws or regulations that talk about de-identification in other jurisdictions. Or other countries, so it's actually a good example of, or a good reference point for workers and policymakers and data custodians in other jurisdictions, just because of the precision that it has with respect to how to de-identify data sets. So I'll talk a little bit about both of these standards, because it's important to understand the choices that we made and the justifications for these choices. So the safe harbor standard in HIPAA essentially lists 18 variables that must be removed from a data set, and if these 18 variables are removed, then this data set is considered de-identified. And here are the 18 variables. Some direct identifiers such as names, telephone numbers, fax numbers, email addresses, social security numbers, and so on. And there's some what are called quasi-identifiers or indirect identifiers such as zip codes, except the first 3 digits of the zip codes under certain conditions, and all elements of dates except year have to be removed as well. So the theory then, if you remove these 18 pieces of information, the data set is considered a de-identified data set. And de-identified data set have a number of characteristics. One is that the HIPAA does not apply to them anymore, because they're not protected health information or personal health information anymore. But also, to disclose a de-identified data set, you do not need to obtain consent or authorization from the patients. Which of course would not be practical in this case, to go back to 113,000 patients and ask for their permission. So the process of de-identification provides the means to disclose that data set for these secondary purposes without having to go back and obtain authorization from the patients to do so. However, the safe harbor is, I would argue, not a good standard to follow for a number of reasons. One reason, and the reasons really apply at both extremes. One reason is that you end up removing some useful information. So if you look at items 2 and 3, for example, they in certain situations, zip codes are important for performing geospatial analysis, and in other situations, dates are important for performing analysis on the health data. So oftentimes you end up removing useful variables from the data set. And then if you look at item 18, any other unique identifying number, characteristic, or code also means that, for example, pseudonyms that are derived from patient ID or provider ID would not be acceptable. And there's another preamble to Safe Harbor, which says that the data custodian must not have actual knowledge that the risk of re-identification is high, which brings us to the second problem of Safe Harbor, is that it's possible to create a data set that meets the Safe Harbor requirements but still have a very high risk of re-identification. And the reason for that is as I will discuss more later on, you have other pieces of information in the data like diagnosis codes and procedure codes that can be quite revealing and can be used to re-identify individuals. So because of these two reasons, the data quality issue and also the situation where Safe Harbor does not provide sufficient protection for complex data sets, which the HHP data set certainly is, it's not really a good standard to use to de-identify under those conditions, or certainly under the situation we were in. So we reverted to the statistical method. So HIPAA applies the reasonableness criterion. Definition of de-identified information is health information that does not identify an individual and with respect to which there is no reasonable basis to believe that the information can be used to identify an individual, and that individual is not individual identifiable health information. I would so emphasize the word no reasonable basis here because it's a reasonableness criterion. It's not the law or the regulation doesn't require perfection. It does not require absolutes. It does not require theoretical or ideal situations. It really has to be demonstrated that there's no reasonable basis that the information can be used to identify an individual. And in that case, it's considered not individual identifiable health information. And this is really important to remember, okay? It's a reasonable criterion. And it's the same criterion used in other jurisdictions as well regarding what's considered identifiable information. Under the statistical standard, you're supposed to apply generally accepted statistical and scientific principles. So we're looking at material that is extensively used and that is somewhat standardized in order to be considered generally accepted statistical and scientific principles. Any principles that are not tested, battle tested, would probably be hard to justify under generally accepted. And then the other criterion on the statistical standard is the risk has to be very small, that the information could be used alone or in combination with other reasonably available information by an anticipated recipient to identify an individual. So two important things here. There's a reasonableness criterion again, but also the risk is very small, and HIPAA does not define what very small is. So I'll talk a little bit about definitions for very small. It's a very important part of the exercise that we went through with the HHP data set. But one has to be able to justify or explain how the eventual risk is deemed to be very small in order to meet the criteria or of the statistical method, or meet the standards under statistical method. So the way we approached this was in order to ensure that the risk is very small, or risk of re-identification is very small, we essentially use this equation. I'll explain this. So big N is the total number of individuals in the population, however defined, right? I is an indicator function which returns 1 or 0 depending on whether the parameters are true or false. Theta is our probability of re-identification, or risk metric. Indexing I is going through all the individuals in the database. And so basically we're computing the probability of re-identification for every record in the database and determining whether it's below a threshold tau. And we're computing then the value within the parenthesis. The big parenthesis is the proportion of records or proportion of individuals in the population, or records in the database if it's a population registry. The proportion of individuals where the probability of re-identification is below a threshold tau. And that proportion of individuals, which are now considered low-risk individuals, has to be greater than some other threshold, alpha. So we have two thresholds here, tau and alpha. Tau is a probability threshold, and alpha is signifies the percentage of the population that has to be low risk for this to be considered a safe data set. And that's the approach that's been used at least around HIPAA often. I'm not saying it's the best approach or it's the right approach or it's what should be used, but it's certainly what has been used often to quantify the risk of identification under the for HIPAA and certainly within Safe Harbor. So we use that as our basis because there's a lot of precedent and justification for this. So the first question is, what are reasonable risk thresholds? What are reasonable taus in that equation, which is our acceptable probability of re-identification? And in practice, the way this has been approached over the last 20 years or so, when you look at the different organizations that have released data, including health data, but also national fiscal agencies, census data, and so on, is they've used multiple thresholds. And the highest threshold that's documented in guidelines or policies and other checklists and so on is 0.33, which is the highest probability of re-identification of a record in a database. And the lowest one that we know of that has been used in practice is 0.05. So that's the range. And 0.2 has been used often, and 0.1 has been used often. And generally speaking, you'd use 0.33 for data releases that are in very trusted contexts where the data recipient has a lot of good practices in place, that the risk of the overall risk of identification is relatively low. There's strong security and privacy practices that exist at the data recipient site. It's not really sensitive data. Possibly consent was sought or some kind of authority was obtained from the patients. So the lowest risk transactions, you'd use a higher threshold. The highest risk transactions, which are essentially the public files or release of public files, you would use a lower threshold. In this case, 0.05. Or at least you'd move that arrow towards the lower threshold as your control over the situation decreases, which would be the case in public use files. There are a lot of precedents for all these four values. Only recently, CMS in the US released a large claims data set on their website, actually multiple data sets using the 0.1 threshold. And in that case, it included those claims included procedures, drugs, and other demographics on the individuals, and it was hundreds of thousands of records were posted publicly using that threshold. So that was a public release file using a 0.1 threshold. Another example was a Canadian example for the public release of discharge abstract data, or at least an analysis of the possible public release of discharge abstract data. And in that case, the data custodian was a bit more conservative and used a threshold of 0.05. So there are precedents for using those thresholds. These numbers have been in use for many years, including very recently for the release of health information. And by many years, I'm talking about 20 years or so. I mean, we're not the first people to release data. There's a lot of precedent here. The other thing to keep in mind is a lot of the risk assessments that are done around the re-identification assume ideal conditions. So if you release the data with a threshold of 0.1, reality is that the actual probability will probably be much lower than that, because real data is messy. Real attacks are difficult, and verifying attacks is also not that straightforward. So these are idealized conditions that set a kind of a boundary for the highest risk that would be acceptable, but in reality, the chances are that the real risk is lower than these thresholds. So the value of tau then, which is the probability of a record being re-identified, we used as I mentioned, there were precedents 0.2 to 0.05. There were some precedents of 0.2 for the public release of health data. The 0.2 threshold for health data is used when in the release of tabular data. So a lot of organizations release tabular data with counts which are essentially the same thing as individual level data when you convert it, but because it's in tabular form, it's considered aggregate data, which in reality it's not. So count tabular data with a threshold of 0.2 has also been used quite often to release health information as well. So for the HHP, after many discussions, the threshold that we used is 0.05. The idea was the decision was to err on the conservative side and use a threshold value of 0.05. So there's no record in the data set that should have a probability of re-identification that's higher than 0.05, with some exceptions. which is where the alpha threshold comes in. The tau parameter is 0.05 in this equation that I showed you earlier on. Now, in terms of precedents, we relied on the some analysis that was done on safe harbor, which showed that 0.04% of the whole U.S. population is unique, and based on that, if we plug in those values here, we can see that essentially what this says is that the HIPAA safe harbor ensures that 0.9996 of the population has a probability of identification that is less than 1. So the tau is 1 and the alpha is 0.996 and 9996 in the equation that I showed you earlier on, and that's the risk level that has been published as for safe harbor and generally accepted. Has been repeated a number of times by various committees and in testimonies and so on. But that's essentially what it is. This is the safe harbor risk level, and you can argue that this has been in place for a number of years. It's accepted because this has been known for a number of years, and there's been no attempt to change it, to change the definition of safe harbor. Therefore, you can argue these are accepted risk levels to use as a starting point, at least for deciding what's acceptable risk or what's very small. So then we wanted to, for the HHP dataset, produce a risk level that is consistent with safe harbor. So we looked at risk exposure, and risk exposure is the product of loss and probability. So if you have a loss, you quantify the loss and you multiply it by the probability of that loss occurring, and that gives you a risk exposure. So in the case of safe harbor, the loss is essentially the proportion of records that are high risk. So it's n, which is your population size, multiplied by this 0.004, and then the probability of that loss occurring, probability of a re-identification occurring, and because the safe harbor analysis used uniqueness, which is essentially a probability of 1, then that's essentially the risk exposure under safe harbor. An equivalent risk exposure then for HHP, where the threshold is 0.05 instead of 1, would mean that you can have 0.8% of your records being high risk. So that's our alpha value. So the alpha value was chosen to be consistent with safe harbor at a risk exposure level. So the risk exposure of HHP is the same risk exposure as the safe harbor data set, at least in terms of setting thresholds. So that gave us the alpha threshold, and the tau threshold 0.05 was based on precedent, erring on the conservative side. So that's how we came up with those two numbers, and those essentially drove everything else. So in terms of overall risk management, it was not only a technical approach. It was a combination of technical and legal measures that were taken to provide overall acceptable risk. So on the legal side, there were express limits in the terms for the competition, banning or prohibiting the attempts at re-identifying the individuals. And I mean, what I would say is that HPN took this issue very, very seriously, very seriously, and so I would not contemplate, thinking about a re-identification attack. And they wanted to make sure that it was an explicit prohibition on re-identification. And partially, this is why some of the rules on linking with other demographic and socioeconomic data sets came from, because that linking could be construed as an attempt at re-identification. So part of the reasoning was that in order to avoid confusion, there'd also be restrictions on the linking with external data sets. And if you've read the rules carefully, you'd see how these things were phrased. And the other potential risk are the other organizations that provide services to HPN members, like the labs and the radiology offices, pharmacies, who may have detailed information on the same individuals, but these are prohibited through other agreements with HPN on what they can do with their data. So there are legal agreements prohibiting them from using those data sets to re-identify the HHP data. So these were the legal limits that we considered. We really didn't consider labs as potential adversaries or attackers on the data set, or pharmacies, because they already had agreements in place with the data custodian regarding what they can and cannot do with that data. So our main concern was when the data is put publicly, and despite the prohibition, someone would still attempt a re-identification. So the data set, the claims data set had three components. The basic information about the members. So age and sex were the main variables that could be used for re-identification. The outcome was days in hospital, and then the claims data set included those other fields for each claim that the patient had made. So specialty of the provider, place of service, the CPT code, which are procedure codes, the date of the claim, diagnosis, the length of stay in days, the provider ID, vendor ID, and pay delay, which is the time it took to receive payment from the payer, from the insurer of the patient. So these are not individuals paying; it's their insurer that would be paying. And all these three tables were, of course, linked by a unique member ID, which allowed you to know for each patient what their claims were and what their hospital stay was. And this is the this is the structure of the data set that was posted online for the HHP competition. So in terms of pre-processing the data set and to prepare it for de-identification, the first task was to create pseudonyms for all of the IDs. You had provider ID, you had member ID, you had vendor ID, you had PCP ID. So of course these were all converted to pseudonyms, because some of the IDs can be relatively easily linked back to individual providers, individual vendors. And so those pseudonyms are not derived from the original value IDs either, according to the definition of derived that's provided by Health and Human Services. And then we also top-coded pay delay and days in hospital at the 99th percentile. The reason for this is that again, the tails for these distributions were quite long, and some individuals had really extreme values, so we wanted to cut it off to at least remove the extreme values in that data set. And then we removed high-risk patients and claims, and high risk from the perspective of re-identification and the perspective of stigmatization. So we had a list of rare and visible diagnoses. So these are diagnoses that are quite rare in the population, and but they're also visible. So rareness is not the only criterion; it's also visible, which makes those individuals quite easily identifiable. So if you have an individual with a really unique feature, say on their face, because of the diagnosis they have, and you know that they live in the counties that HPN offers, these individuals may be quite easy to identify. So so those individuals were removed based on their ICD-9 codes. And then we identified sensitive diagnoses and procedures, and these individuals with these sensitive diagnoses and procedures were also removed for a number of reasons. One, there are laws specifically targeting the disclosure of that kind of information, and the other reason was just from because of the just very high sensitivity of that information, of these diagnoses, that it was felt that these individuals would be more sensitive to having that information included in a competition. So we looked at individuals who had HIV infection, individual physical, psychological, and sexual abuse, or inflicted or assault as their diagnosis, substance abuse or dependence, psychosexual disorders or mental retardation, plastic surgery for unacceptable cosmetic appearance. So the reason we put plastic surgery is we did a number of studies on patients who proactively locked their medical records. So in certain jurisdictions, patients have the right to lock their medical records, and when we did a study to understand which type of patients lock their medical records and for what reason, it turned out that individuals who had plastic surgery are the one type of patients who lock their medical records. They don't want anybody to know that they've had plastic surgery. So given that patients proactively are known, these type of patients are practically known to lock their medical records. Clearly, they have some sensitivity around that diagnosis. And patients having undergone procedures indicating intersex surgery, so sex change, these procedures, patients with these procedures were removed. And we didn't just remove the claims, we removed the whole patient, because you can tell if a person had sex change, you would be able to tell from other information in their record through a longitudinal claim that they've had a sex change. So the fact that that procedure code was removed because of the inferences that one can make, it was important to remove that whole patient. And then patients who had abortions as well, and patients with alcohol or drug abuse or dependence. And then patients where the place of service was mentally intermediate care for a mentally retarded residential or non-residential substance abuse treatment facility. So that was the kind of high-level summary of the list of stigmatized conditions that were removed, patients with these stigmatized conditions that were removed at the outset, because for those patients, for HPN, the only acceptable risk was 0, so they were removed. And then we did another analysis where we removed unique provider and vendor patterns. So there was a pre-release of the data adversarial analysis or attack that was commissioned by HPN to get an independent party to evaluate the data identification, and as part of that analysis, the determination of patterns from essentially clustering provider and vendor IDs was deemed to be a path to re-identification. So we did some additional manipulations to reduce the probability of successful re-identification using those patterns. And this is why you'll see in the data set there's some provider and vendor IDs that have been suppressed. So another important thing that was done was a truncation of claims. And the reason for that, again, this has a heavy tail distribution. Some patients had an unusually large number of claims per year. These individuals really stand out. There are not many. There are not many of those individuals, but they do stand out just because of the unusually high number of claims that they've made during that period. And that makes those individuals much more easily re-identifiable. So we wanted to determine or develop a way to remove this. So the approach we took at the time was simply to truncate at the 95th percentile. That set a limit on the maximum number of claims that a patient could have. This only affected 9,500 odd patients that had at least one claim truncated. But in general, not many patients had many claims truncated, just because the tail was very thin as you reached a large number of claims. But again, these were extreme individuals from a number of claims perspective. And in order to decide which claims to remove, we computed a score, which is described in the paper. And the score is essentially a function of how unique a claim is. So each claim was given a score. So if a patient had a unique combination of, say, procedures and diagnoses for their age and sex, then they were scored highly. There was a more unique claim among other patients, and then the claims that had a higher score were truncated until the 95th percentile value was reached. So that was essentially the process that was used at the time. Anyway, I'll come back to improvements that, if we were to do this again, what improvements would be made. And I think that the scheme for truncation, since then we've developed improved versions of this that will result in less information being removed. But at least for HHP, that's what we did. So out of 113,000 patients, 9,556 had at least one claim truncated during this process. And this is standard practice. If I just go back in terms of disclosure control, top coding or truncation according to a percentile value between 95 and 99 or 99.5 percentile has been common practice when there are concerns about extreme outliers. Okay, so then from the more substantive analysis, we looked at plausible attacks. We considered 3 attacks. One was the nosy neighbor scenario, where the adversary, there's an adversary from kind of a circle of acquaintances of a patient who knows a patient and has some background information about them that can be used for matching. The background information can be any of the fields that I showed you earlier on: age, sex, diagnosis code, procedures, etc. Attack 2 is matching with the voter registration list for the counties covered by HPN. There are restrictions on the voter registration use of voter registration lists in California. So, if someone was to launch an attack using voter registration lists, that would go against the terms of use of those lists as well, which would create additional problems for whoever tried that. But we felt that this was such an obvious and highly reported type of attack that it was useful to evaluate that risk. And voter registration list has identity information, so usually they're a good source for matching with other databases that can then be used in combination for an attack. So I wanted to see how successful this would be. Another attack was the state inpatient database, which include discharge summaries for all hospitalized patients in California, and that data is available. And for research purposes and analysis purposes. So we wanted to evaluate the risk of identification if someone tried to match the HHP dataset with that. The risk was not really from identifying patients, but from augmenting the existing data with additional information from the SID. If you augment the existing data, then whatever risk assessment we did in terms of thresholds and so on would be would not be accurate anymore, because if you add more information, then the risk would go up, of course. So we wanted to evaluate how successful such an attack would be. For attack 2 and 3, we developed a closed form estimate of the expected proportion of records that could be matched. So, for example, we take attack number 3, take the SID. So we obtain the SIDs for the 3 years of the competition, and for any random sample from the SID of the same size as the HHP dataset, we were able to compute the expected proportion of records that could be successfully matched. And the article in the paper appendix describes that formulation. And that's just a more efficient way, rather than doing some kind of Monte Carlo simulation. And the same thing for the voter registration list. We used the census data for the relevant counties and computed the expected proportion of records that could be successfully matched if you obtain the voter registration list and match it to a sample of the same size as the HHP dataset. I'll show you those results later on. And this is for any sample, so it's kind of the expected value across any sample of that size. Numerically, if we manage attack number 1, then attacks 2 and 3 would also be managed. And this is just because of the relationships among the different re-identification risk metrics. So if we manage 1, 2 and 3 are automatically managed, and our results substantiate that. So we managed 1, which is what we focused on. We still measured 2 and 3, but 2 and 3 were almost by definition lower than 1 because we managed 1. And in order to manage attack number 1, we used the identification algorithms that can reduce the precision in the data until the risk of re-identification met our criteria, the tau and alpha that I showed you earlier on. And also we did an extensive attack simulation. So we built an attack simulation platform that can simulate different types of attacks on the data under different assumptions, and we ran a very large number of those simulations. Some of them are included in the article as well, to simulate different attacks under different assumptions for adversaries with a large variety and cross-section of background information that can be used for attack. We simulated different data quality as well, where you have high data quality that the adversary would have and low data quality, just to get an understanding of the range of risks that exist. And we presented the highest risk results in the paper, the most assumptions about the adversary having the most background knowledge, the most information to attack with. So for managing attack 1, we did the identification, but we also simulated the attacks. And the simulation tool was built by a completely independent group, developers unrelated to the first group that did the identification. So we wanted to ensure that there was no dependencies in terms of the assumptions made between those two different applications that were used, the identification application and the simulated attack application. So in terms of the identification that was applied for attack 1, we used generalization. Now we use generalization because it's a practical approach to reduce the probability of re-identification, and it has advantages over other common approaches. Other common approaches that have been discussed or mentioned are, of course, one of them was creating synthetic data, and we actually discussed in the context of the HHP if we could create synthetic data instead of releasing actual data, and we did a number of evaluations of synthetic data scenarios to see whether it's possible to create a safe synthetic data. And at the end it was decided that this was not appropriate for a number of reasons. We felt also the risk of identification was going to be high. There was actually no solution to attack synthetic data at the time, but since then we've found a researcher who's developed a way to attack the synthetic data that we were considering. So our intuition turned out to be quite accurate, that attacking the synthetic data was plausible, and it was just a matter of time before someone develops that. But the other commonly used approach is to add noise. And again, we published a paper recently on the differential privacy, which is the main theoretical basis that some folks have suggested should be used for the addition of noise. And we've identified some important weaknesses in the differential privacy model as it pertains to health data, and certainly as it pertains to the public release of health data. So using that as the basis was at least at this point was not appropriate, we felt. And also, of course, there's a very large literature on removal of noise from data. There's if you go to your electrical engineering textbooks, you'll find many books written about filtering technologies to remove noise from communication channels. If you apply those filters to data, and there have been papers published in the disclosure control community around this as well, removal of noise from data sets. So addition of noise has a lot of issues around it. Plus, of course, the practical issue is that a lot of our just from our other work, a lot of data users don't like data with noise in it because they don't know how much noise was added and what impact it would have on their conclusions, whether the conclusions would be accurate or not. So we use generalization. Essentially, generalization is, as you see here, you define hierarchies, reducing the precision of each variable. So some simple examples: you have the full date of birth, or changed to month, year to a year. It could be changed to a 5-year age interval, 10-year age interval, and then you have gender, which is just generalized to a nondescript person. So examples from the HHP: the diagnosis codes were generalized to primary condition groups. We tried a number of different generalization schemes for diagnosis codes, and PCGs seem to be quite related because they're risk-based. So diagnosis codes are grouped based on the how sick the patient is, basically. And given the nature of the competition, that grouping made a lot of sense, as opposed to other ways of grouping diagnosis codes. And then the Charlson index, which describes the severity of comorbidities, was also included as another way to indicate how sick these patients were. And of course, the procedure codes were generalized to higher level codes. The dates was generalized to dates since the first claim, and so on. And these generalizations are all described. But for each one of those in the paper, for each one of these variables, we defined a generalization hierarchy, and then we used an algorithm which is called optimal lattice anonymization, modified version of this, which essentially creates a lattice that looks something like this. That shows all the possible generalizations. So you start from the bottom with all the data, all the variables at the lowest level of detail, and then right at the top are all the variables with the least amount of detail. So the bottom is most detail, top least detail, and then the paths show individual generalizations of the hierarchies for each one of these variables. So you construct a lattice which describes all the possible generalizations on all the variables. And then the algorithm essentially navigates this lattice in a very efficient way and evaluates the risk at each one of these nodes. And if the risk at each one of these nodes is below our threshold, so meets the criteria that we mentioned earlier on, the 0.05 and 0.008, so our alpha and tau thresholds, then that node was considered a possible solution or a good node. And the algorithm uses various techniques or heuristics to navigate this lattice efficiently, and it does produce the globally optimal result. If there are multiple nodes that match, we use an entropy-based metric to choose the node that results in the least distortion to the data. So it tries to maintain the highest quality data set if there are multiple nodes that meet the alpha tau criteria that we saw earlier on. And that's all been published, and the algorithm has been described. However, here there was or a number of modifications to the basic algorithm, and that had to do with the idea of the adversary power. And the adversary power essentially means that the adversary will not have information about all the claims. And adversary power is really important when you talk about longitudinal data sets. So let's say a patient has 40 claims, and each claim has 6 or 7 variables. What are the chances that an adversary would have background information on all 6 or 7 variables on all 40 claims? If an adversary has that much information, then that would be quite incredible. Most patients don't have that much information or know that much about themselves, let alone an adversary who's trying to attack. And if you exclude the other healthcare providers like the labs and the pharmacies and other providers, then it's just not a very plausible attack scenario to say an adversary knows those 7 variables on all claims. So we make other assumptions, and this again is coming out of disclosure control literature. You make assumptions about how much information would the adversary have, how many claims would they have information about. So for example, if we say that the adversary has information about at most 5 claims, then the challenge is, if you have 40 claims, which 5 claims does the adversary know about? And of course this is a combinatorial problem, because you'd have to look at all possible combinations of 5 claims out of 40, and you'd have to repeat this for each one of the 113,000 patients. And if any of those combinations doesn't meet our alpha tau thresholds, then that patient would be considered as high risk. So of course we needed to find efficient ways to evaluate that without considering all possible combinations of 5 out of 40 in this particular example. And then the other thing we looked at, of course, is that what should the number be? What's the adversary power? And really it depends on the diversity of the claims of the patient. So as a simple example, a patient who has a chronic condition, let's say a kidney dialysis patient, would be going back over and over again. So the pattern of claims for that patient would be the same over a large period of time. So we used a diversity metric that's used in ecology to evaluate the diversity in claims, to determine how different the claims are over time. Now, patients who are the kidney dialysis patient, if you know one claim, if you know that this is a kidney dialysis patient, and given that this is a chronic condition and that it is recurring on a weekly basis, you can predict a lot of claims for that patient. So you'll know that because of the low diversity, you'll know that that patient has a set of claims that look very similar to the one you know. So the predictability of claims for a low diversity patient is high, and therefore you can assume that the adversary will have a lot of power for that patient. Whereas for a patient who has a number of acute incidents that are unrelated to each other, so in that case there's a lot of diversity in terms of diagnosis and the procedures and so on, then knowing one claim does not help you predict other claims. Okay, sorry about that. There was another public announcement. The hospital. Patients with a high diversity are much difficult for an adversary to know a lot about them, because knowing one claim doesn't help you predict many of the other claims. So we took that into account in determining the adversary power. So adversary power really was a function of the patient. It was not constant across patient, but each patient would have a different adversary power, and this allowed us to customize the risk assessment to the specific characteristics of the patient. And then we used a bootstrap-based approach to estimate the, rather than look at all possible combinations, we used bootstrapping to estimate whether the patients meet the alpha tau criterion or not. So now I'll just present some quick results. So the original data set then that was released, or the initial assessment that we did, had a 0.84% chance of individuals being re-identified. So this is from the simulated attacks. 0.84% of the individuals were, assuming a power of 5, were could be correctly re-identified, and if you go up to a power of 15, 1.17% could be re-identified. And this assumes 15 claims, all the variables, so 15 times 7, because the adversary would know all the pieces of information. And then ordered, so in the original first row, we assumed that the adversary does not know the order of the claims, just knows the claims, the information in the claims. And the bottom one, we assumed that the adversary know the order of the claims, and again, the risk did not increase appreciably. And as you can see here, even under the worst case assumptions, the percentage of records that can be re-identified is still below 5%, plus 0.8%, which is our original threshold. So at a power of 15, it means the adversary knows more than 100 pieces of information about the individual, which is a tremendous amount of information. I mean, if an attacker knowing 100 different things about you over time and use that information to launch an attack, that's a lot of information. But even under that very strong assumption, the proportion of percentage of individuals that could be correctly identified based on very conservative simulations was below the threshold. That was under ideal conditions, was below the threshold. And then just to show you some of the other results in terms of matching with the SID, we looked at the percentage of records that could potentially be matched with the state inpatient database for the counties, for California, and matching on different variables. And again, the percentage of correct matches is quite small. So if someone were to attempt to match with the SID, their hit rate, the expected hit rate, of course you may get lucky, but the expected hit rate would be very small, certainly below our threshold again. But the others, of course, you wouldn't know which record were correctly matched, because some of the matches will not be correct matches. And you wouldn't know which ones are the correct matches and which ones are not. So that's something else to keep in mind. So even if someone were to attempt that type of attack, the risk is below our predefined threshold. I know I'm going a bit over time, so I'll just finish up by saying I think two important things we could do differently in the future is improve the truncation method, and also use less computation intensive ways for estimating re-identification risk. Using the bootstrap was actually very computationally intensive, and required a lot of evaluation. And also simulated attacks were also computationally intensive. So we know how to do this better next time in terms of efficiency, and the truncation, of course, will result in more data being released. And I'll leave it at that, and I'll open it to questions. I apologize running a little bit behind, but I think we'll leave some time for questions, or take some questions from folks on the line, just wait a couple of minutes to see if anybody has any questions. And thank you, of course, for listening. And as I mentioned, we'll be putting the recording and the slides online, hopefully in the next couple of days. So in order to ask questions, you can just enter them in the text box that appears in your on your screen, and then when you enter the question, I'll see it when it pops up here. Okay, so does that mean there are no questions? Oh, there is questions. Okay. So you mentioned, the question was, you mentioned that the data is a subsample of all the patients. What criteria were used to determine the sample? So the sampling fraction is taken into account in measuring the probability. So as I showed you earlier on, the let me go back here. The equation had a theta I in it, this theta I is essentially the probability of re-identification, and the sampling fraction is taken into account in computing that probability. I didn't get into that much. It's described a little bit in the paper how that's computed, but you'll see that the sampling fraction is taken into account. So as we were doing the de-identification, we chose, try to again trade off the amount of de-identification with the amount of subsampling to allow for to ensure that we meet our thresholds, the alpha and tau thresholds and so on, but try to minimize the amount of distortion to the data as well. So in some cases, or as part of the discussion, we're trying to trade off, should we reduce the precision of variable X? Is it really important for modeling? How much does it contribute to the prediction accuracy of the model? And if it was really important, then maybe we should reduce the sample a little bit more to reduce the risk, but retain as much information in that variable given its value. So that's how it played in. The next question was, does de-identification have any side effect on the prediction process? De-identification will always have an impact. The real question is, how much impact does de-identification have on the prediction process? As I mentioned, as part of the exercise was to do some modeling along the way to evaluate the impact of the de-identification on accuracy or on the prediction accuracy. And I'll give you one example. The grouping of diagnosis codes into PCGs, had we provided the raw diagnosis codes, the entrants could have grouped them in different way, and they may have been able to produce better models through that grouping. But on the other hand, the PCG is already a grouping based on risk, and given that days of hospitalization would be a direct function of the severity of illness of the patient, PCG seemed like a good way to group the information. Could someone have produced a better grouping? I'm sure yes. The answer is yes. But the risks would have been much higher to had the original ICD-9 codes been shared. So it was really a balancing act, trying to minimize the impact but still provide these strong guarantees, the strong quantitative guarantees that were needed in order to release the data set. The next question was, if one patient has records in 2 years and his claims in 1 year were truncated, will those similar claims in the other year also be truncated, although his claims in that second year are not so many and there's no need to truncate? No, the answer is no. The truncations were done on a year-by-year basis. So if a patient had 300 claims in year 1 and 20 claims in year 2, then only the claims in year 1 would be truncated to bring it back down to the 95th percentile, but the claims in year 2 would not be affected. The next question was, you mentioned this took months. How many months, and what was the order of magnitude of cost? Do you expect cost to drop based on what you've learned? There were 3 data releases, and each data release took a month. So it was, and the data releases were at monthly intervals. So it was a month for each data release, and I would say a month afterwards to document everything in order to meet the HIPAA requirements, which required documentation of the process that was used to de-identify. There were other data sets that other information like lab and drugs which were not included in detail, and this is another topic for discussion, because the analysis that went into drugs and labs was also quite extensive and very interesting, and once we get approval from HPN, we'll be able to talk more about the issues around the release of drugs and lab data, which I'm hopeful will happen soon. But roughly a month per data release. I think that's a good approximation. And then would it drop based on what we've learned? Absolutely. I think we had to develop new methods in order to de-identify this data set in terms of truncation and dealing with the adversary power issue. Although there's work on the adversary power issue, it didn't scale. This is well, the data set that was released was about 2.6 million records. The original data set was much larger before the subsampling. Therefore, the existing methods for dealing with adversary power were many of them were not going to scale to large data sets. They were just not able to handle this. So we had to develop new ways and evaluate new ways. But now that this is done, I think second time round will be a lot easier and much faster to do. Next question. You mentioned you have suppressed unique provider and vendor patterns. Can you elaborate on this? Is the ID of the vendor provider unique? Yeah, the ID of vendor providers is unique. They're pseudonyms, though. They're not real IDs. But and this is described more in the paper as well, but the basic idea is that we looked at whether, for example, the providers would cluster in under certain diagnoses or procedures, and if these clusters were very small, then we applied again optimization algorithms that minimize the amount of suppression. So, and these are globally optimal algorithms that really do find the minimal amount of suppression in order to make it remove the patterns with small number of providers and vendors in them. And this is why you'll see some suppressions in those IDs. And this was driven largely by the adversarial analysis that was done, or attack that was commissioned by HPN as part of this work to see if the data could be re-identified. And this third party who did this work identified the clustering as a potential mode of attack, and so we tried to address that as part of the identification, but again minimize the impact on the data. We noticed that pay delay has significantly different distribution in years 1, 2, and 3. Is this due to the suppression of pay delay? Pay delay there was very little suppression in pay delay. So as I mentioned, it was only the extremes of the tails that were suppressed. So any strange patterns in pay delay are in the data. They're not due to the any suppression that was done, because it was really very few claims had that done to them, and so it wouldn't affect the overall distributions. So I wouldn't consider the identification as being a cause of that. The next question is okay. This is in the paper. Length of stay and days since first claim were significantly negatively correlated. Can you explain this? So these were not correlations in the variables themselves. They were correlations in the diversity of them. So patients who had a highly diverse length of stay, so a lot of variation in their length of stay, tended to have a very little variation in their essentially the intervals between their claims. So the intervals between the claims tended to be quite similar, but when they came to stay, there was a lot of variation in their length of stay. So that's what this correlation means. And at 0.44, that's a good kind of medium-sized correlation here, moderate correlation. So there's something there in terms of diversity of these variables. It's not the variables themselves, but how diverse they are across multiple claims. And this was the main driver for us to consider to do the adversary power analysis on a variable by variable basis, rather than combine all the variables and look at diversity by claim. We looked at it by individual variable, because they were not all correlated. The example that is in the question, the correlation was high, but a lot of the diversity among the variables in the claims was the correlations were not high. A lot of them were low correlations or non-existent correlations. So I think hopefully this answers your question. I think that's the last question here. So with that, I think what I'll say is thank you very much, because we're